I'm a professor here at USF. I'm a child and adolescent psychiatrist as well as a general psychiatrist, but I treat mostly children, adolescents, kind of transitional aged youth, kind of folks in their 20s. And I've been asked recently to talk about ADHD versus kind of trauma and differentiating those presentations. So I'm going to talk for, I'll have a few slides here and I'll try to leave time for questions if people have questions. And there's a little time to be able to transition back into your day if you've got appointments. So, right? So, so there's a little in your teams. There's sort of a little raise your hand function if you have a question while I'm talking. You can probably unmute, or you can use the little raise your hand function. It depends on if you're. It's just a little. Depends on whether you're on an iPad. It's like a little circle with a hand, a little face with a hand. On a computer, it's just a little hand there. Okay. So I've got two screens here. So I'm going to start with just the basics. So what is ADHD? I think we all know that ADHD is a syndrome where people have symptoms of inattention and or hyperactivity and impulsivity that are present for at least 6 months, that occur in at least 2 settings. They're present by age 12. They're not developmentally appropriate. They are maladaptive, causing impairment in functioning socially, academically, or occupationally. And of course, I'll just go to some of the symptoms here. We kind of know what the symptoms are. Inattentive symptoms like making careless mistakes, trouble listening, trouble with attention, losing things, not finishing what they've started, not staying organized, not knowing where things are, not turning work in they've done, being reluctant to do tasks that require sustained mental effort. So that's looks like really bad procrastination, just not wanting to start something because it feels like it's too much, or kids will say it's too much work to do. They're forgetful in daily routines and they're easily distracted. If they're hyperactive and impulsive, may run or climb excessively, be unable to wait their turn, not be able to play quietly, be on the go all the time, fidget with their hands and feet, blurt out answers, have trouble staying in their seat, talk excessively, or tend to interrupt people. So those are kind of the symptoms. As I said, these typically are causing impairment before they should be present before age 12 and causing impairment. Now, sometimes they're not causing impairment because all the adults are doing what they need to try to help these kids be successful. So they may be, sometimes you hear people say, well, they've done fine in school, in elementary school, they're getting good grades. But when you dig into it a little bit, it's really because mom and the teacher are talking to each other every day. And mom is saying the homework is in the blue folder on the right side that's been completed, and the teacher's emailing back, great, I sent home 3 worksheets to do over the weekend or whatever. So sometimes the kid is doing fine because all the other people in their life are really structuring things for them and keeping them on task. So as very often we'll see that kids begin to really struggle with symptoms in middle school, where it's no longer one teacher with their parent kind of coordinating things. It's 6 teachers, and the middle schools are really focused on having the kids try to do it on their own, and we see the kids maybe crashing and burning at that point, just not able to be successful. So ADHD occurs in about 5 to 10% of school-aged kids. By adulthood, about half of people grow out of it. So that's between 2 and 5% of adults have ADHD. We know that ADHD occurs more in people who are born prematurely, people who are born with low birth weight, regardless of the timing of their birth. If they're less than 5 pounds, they're more likely to have ADHD. And if they were exposed to consistent maternal smoking during the pregnancy, they're more likely to have ADHD. We know that it occurs more in males than females. And in males, there's up to a 70% concordance rate as far as genetics. It's passed very strongly from fathers to sons. So a couple mutations that are common among fathers and among males that can create ADHD. One is a abnormality in the gene for the dopamine transporter molecule, so it's not moving dopamine around correctly, and one is for the dopamine 4 receptor. So those abnormalities are highly genetically passed on. Females tend to have more of the inattentive type than the hyperactive type, so they sometimes are missed. Teachers do tolerate girls looking out the window, daydreaming more than the boys, jumping around class, poking everybody, touching everybody. That gets noticed a little bit more. So um, you all feel free to leave your cameras on if you want. What happened here? All right. Okay. So differential diagnosis, that there's many things that can cause inattention. The ADHD is not the only thing that can cause inattention, or can cause difficulties with hyperactivity, poor impulse control. That includes things like Fragile X, genetic conditions like Fragile X, just anything that causes intellectual disability. If kids don't have good intellectual disability, they're behind on all kinds of milestones, including self-control, including learning. So they're having difficulties. So lots of different genetic syndromes, especially those that cause intellectual disability, could cause inattention. As we mentioned, if a child has had tobacco exposure, they may have ADHD. If they've had alcohol exposure in utero, they might have fetal alcohol syndrome that's undiagnosed and associated with difficulties paying attention, or if they've had other drugs of abuse exposure in utero. And then sometimes drugs, like if the mother had to take anticonvulsant medications, a lot of those can cause difficulties with concentration and focus. There's perinatal things that can cause trouble with focusing. If the child had any kind of hypoxia during the birth or after the birth, again, if they had low birth weight, if there was a prolonged labor or use of forceps during the birthing process, that can cause trouble with inattention. Environmental toxins, we all know about lead, but also secondhand smoke can create difficulties with concentration. Obviously, if kids have had a traumatic brain injury or a concussion, that can cause difficulties. And, obviously, sensory difficulties if kids aren't hearing well. So, we got to think about this in the kids that we see that if we hear that a child is having trouble with attention or regulating themselves, getting in trouble a lot at school, and they've had a lot of otitis media when they were little or had PE tubes put in, we have to make sure we've got good testing of their hearing, because a child may have decreased hearing on one side or another that causes them to be off task, not paying attention. It may be just shifting the kids' seating so the teacher's on their better side of hearing. That can be helpful. And obviously vision difficulties as well. Any of you who wore glasses when you were a kid, I glasses are a new thing for me after 40, but for people who have glasses as a young child, they don't know that the world is blurry. They can't tell you that things are blurry because it's just what they've always seen. So, around age 8, we start to find out that kids, can begin to articulate or realize that there's, they can say that I can't see these letters, and people may begin to be saying to them, that doesn't seem right. These letters should be clear to you. And so making sure we've addressed sensory issues is always important in the differential for ADHD. There's also a lot of psychiatric comorbidities with ADHD. There's half of the kids with ADHD have oppositional defiant disorder. So there's half of the kids with ADHD that are perfectly lovely to treat. I call them happy-go-lucky puppies. They're just kind of all over the place, running around, but they're happy. And you're like, get off of the table. Okay, stop touching your sister. Okay. And they just they're happy and redirectable, but like a lot of work. Whereas then there's the other half that have oppositional defiant disorder, who tend to be irritable. They give you a lot of pushback, talking back to parents, adults, harassing their peers, annoying people, they're angry, irritable kind of kids. About a third of those kids are actually doing things that are significant rule breaking, violating the rules of others, causing property damage, lying, hurting people, hurting animals, things like that. About a third have a learning disorder of some type, not just inattention, but trouble with reversing letters, dyslexia, dyscalculia, a writing expression disorder, some kind of learning disorder, or processing speed that's slow. About a third have an anxiety disorder. About a third have a depressive disorder. About a third have a developmental coordination disorder. So some kids with ADHD are very physically skilled and they're wonderful athletes, or they may be really great at, mechanically manipulating things. And then there's a third of the kids who are just, they're prone to injury. They have a lot of cerebellar vermis. Their cerebellar vermis is smaller. They have timing deficits. They're tripping. They're falling. They, can't do things very well. And about 10% have bipolar, and about 10% have post-traumatic stress disorder. So they may be comorbid, or it also can be that it can be hard to tell if it's ADHD at all and instead it might be trauma. So we'll get to that in a few minutes. So, what are the outcomes for people with ADHD? Well, we're always trying to recognize ADHD and make sure there's some kind of recognition of it and some ways of treating it or addressing it, because the outcomes are not great, right? People who are untreated who have ADHD have lower rates of completing high school. They have lower rates of attending college, lower rates of getting a college degree. They have higher rates of substance use, higher than the average population. So that gets a little confusing. Sometimes people say, oh, well, all these kids with ADHD, you give them a stimulant and they end up with substance use. Well, really, even if you don't treat them, they have higher rates of substance use. And most of the newer studies show that if you treat their ADHD, you can kind of pull their substance use back down to the general population level, which is 15% of the population having a substance abuse problem. They have financial problems. They forget to pay their bills, or they've got their bills on auto pay, but they forgot that they lost the job last week and now there's no money in the account. So they pay a lot of late fees for things, or reconnection fees because they got their power turned off too many times or something like that. So they've got a lot of financial problems. They can't plan and save for things. They have more traffic accidents, so they get injured often in a lot of traffic accidents. I've got one kid who's like 22, who's been in 5 motor vehicle accidents, has a lot of back pain from serious accidents. So they have more traffic accidents. They have more interpersonal problems, including divorce, or difficulties with tense relationships with their kids, tense relationships with family or friends. They tend to, I don't have it on here, but they tend to change jobs more often. So you kind of ask them, why did you change jobs? Getting a little bit of it for an adult, you can hear that they've forgotten to show up to work, or weren't listening, weren't following directions, couldn't hold the directions in their mind, weren't completing tasks. And they've got an increased risk of being in jail, breaking the law, those kind of problems. So we want to treat kids with ADHD, or make sure people are thinking about how to help kids be successful, because there's a lot of negative things that can happen as an adult if you have ADHD. From a neurobiology standpoint, kids with ADHD have usually it's a smaller brain. They've got a smaller brain with more gray matter than white matter relative to other controls. And what does that mean? It means that their brain is myelinating more slowly than typically developing peers. So there's kind of a gap. When they've done MRI studies, you see that their brains, if you look at the MRI studies, their brains look 2 to 3 years behind their peers, which is what accounts for the fact that their attention span isn't what we expect at their age. Their overall self-control isn't what we expect at their age, because their brain literally isn't as old as their chronological age. And there's a variety of structures that are affected, in particular the splenium of the corpus callosum, which is relaying information between the two sides of the brain. They have a smaller inferior cerebellar vermis, which relates to those timing deficits. And they have some difficulties in the right caudate, which relates to some of the movement difficulties they have. And they've got abnormal catecholamine functioning. Like I said, may have abnormalities in how dopamine is responded to and how it's moved around in the brain. So from a neurobiologic standpoint, there's a number of things going on there. And it's just a picture from NIH that shows that the purple is more myelinated areas, and you can see that as you go through childhood and into adulthood, you're getting more and more of the blue and the purple, which is the myelinated parts of the brain. The last part to myelinate is your prefrontal cortex. Your prefrontal cortex is where your executive functions are. That's things like planning, organizing, sequencing. Those are the things that you lose in Alzheimer's disease, right? Your executive functioning, because that same area is atrophying. And your brain doesn't fully myelinate until you're 25. So sometimes when parents ask me, like, well, when is he going to grow out of this? What age? I'm like, by the time he's 25, probably, because we've got continued myelination going on. So it's difficult. Kids grow out of the symptoms at very highly variable rates. And some of it is because some of it depends on what kind of symptoms they're having and whether it's really residing in a part of the brain, what's most problematic for this kid and whether it's a part of the brain that's myelinating last. So there's, like I said, the executive functioning due to problems with the frontal lobe involvement or planning, organizing, sequencing, as well as trouble shifting to a new activity. So, the teacher says, put away your math books and take out your reading books, turn to page 20. That's hard for a kid with ADHD to stop what they're doing and shift to a new thing. So sometimes people talk about hyper focusing. They're getting stuck on one activity. They can't shift from one activity to another. So it takes them a long time to get into an activity, and then it's really hard to get them to stop that activity. They've got problems in the communication between their cerebellum, their prefrontal cortex, and their basal ganglia, the striatal network. So that can turn into excess movement, the hyperactivity, poor timing of what they're doing, poor sequencing. And kids with ADHD, some of them really have trouble with like just not being able to like speed up what you're doing. So you say, okay, we've only got 5 more minutes before we have to leave, and you speed yourself up. Some of them cannot do that. Some of them cannot. When they sit down to do their work, they can't try to go faster if they're almost out of time, that kind of thing. So the myelination, so there isn't really everybody so there's a question in the chat about late myelination. So yeah, as people's myelination improves, we see diminishing of symptoms, but there isn't really any great way to predict who's going to grow out of it and who isn't. And even people who previously had ADHD have, they're not as strong in all those domains as maybe people who never had ADHD. So there's like people who just end up with subclinical sort of ADHD that we haven't really found yet how to predict who's going to grow out of it. It's like the less severe your symptoms are, the more likely you are to do better. Like the more severe it is when you're young, the more it's going to probably persist. Obviously when we make the diagnosis, we get multiple informants. We ask parents, we ask teachers, we might ask a daycare provider or a coach. We get information from at least 2 informants, usually 2 settings, using standardized forms. So each of your clinics probably has something that you use, and there's many forms. You can use the Connors, you can use the ADHD-4, I'm just going to comment there. You can use the Vanderbilt, you can use a much more extensive questionnaire, like the child behavior checklist. It's also called the Achenbach. That has like 100 questions, and it asks not just about ADHD, but about anxiety, depression, other kind of symptom domains. So you have to kind of think about what you're using the form for. The Vanderbilt helps screen for oppositional defiant disorder and conduct disorder, and a little bit about peer relationships and anxiety. So that's a nice form that a lot of us use. It's in the public domain, so it's free, but it does not have norms. So you can't say, oh, whereas the Connors asks about some of those things, but the Connors gives you norms. So you could say this kid is more than 2 standard deviations above the norm. The way you filled this out, this child's hyperactivity or inattention is 1 standard deviation above the norm, or more than 2 standard deviations above the norm. Sometimes that helps some parents, feel more comfortable about treating the child if they can see that like multiple informants are rating the child as an outlier. So the rating scales sometimes help the adults involved get buy-in to a diagnosis to see that there's a difference. Other times it's good just for helping to collect symptoms quickly to help with your diagnosis. And then you can also use rating scales to kind of track improvement. So you have to think about what you're using the form for. What's the cost? Do you want norms or not? How long is the form? The ADHD-4 is the shortest. It's just the 18 symptoms of ADHD that people rate. And it does have norms, so that could be nice. It's a good one to use to track. You might, depending on the presentation, want to get IQ testing or achievement testing if you strongly suspect like an intellectual delay, or you strongly suspect a learning disorder. Sometimes we will treat first to kind of see what improvement we get, and then if the child's not making the improvements we expect with some addressing ADHD, we may then get the testing, because the testing is harder to get based on having psychologists available to do that and having insurance cover it, and then figuring out whether the schools take that information and do anything with it. So differentiating ADHD from trauma. So that can be difficult because abnormal arousal and emotional reactivity that folks have with PTSD overlaps with ADHD symptoms. So kids who have hypervigilance can appear very distracted. I worked with one little girl, she was like in 1st grade, and she'd had some physical abuse, mostly like neglect. Like she got removed when dad like brought her to a strip club or something, you can't take people under 18 to a strip club. So it was mostly neglect, but she was, she had seen a lot of things in her little life there. And so at school, what the teacher said was anytime there was windows in both sides of the classroom, and anytime a car pulled up to school, she'd be like, oh, is that my dad? Is he coming to get me? anytime she heard a male voice in the hallway, she'd run to the door. I said, my dad, my dad's here. And she was like, she wasn't really able to see her dad very much, and she really wanted to see him. And so, but she was also kind of worried about what was going on. Like she would say, like, my dad's here, are the police going to come? So she was kind of just very hyper vigilant, which was contributing to distraction. So it was a little hard to tell what was going on. Was that all PTSD? Was there ADHD in there as well? Part of PTSD can be poor concentration. That's part of the hyperarousal symptoms. Having sleep disturbance. That's not part of ADHD, but we know half of kids with ADHD have sleep disturbance. And obviously, and if you're not sleeping well, you clearly can look like you have inattention and poor concentration, right? Like sleep problems, sleep apnea is one of the things I didn't put in there on the differential for kids with ADHD. But American Academy of Sleep Medicine has said that if a child has behavior problems and snores, they should get a sleep study. So, so if a kid is having sleep problems, you might want to know: do they snore? Could they have a sleep problem, or are they having bad dreams, having sleep problems and avoiding sleep? Because some kids don't want to go to sleep because they're having nightmares from PTSD, or just that they can't go to sleep because they're kind of on high arousal all the time because of the PTSD. So if they're having sleep problems, they might want to know: are there nightmares? Are there scary things that have happened in life? They're kind of keeping them on high alert and that they can't sleep and relax. You can have reckless behavior in both PTSD and ADHD. Some kids with PTSD are rather than being inhibited, they're very reckless, kind of, again, over aroused and not able to regulate themselves well. They both can have irritability. It's like 90+% of kids with ADHD have irritability, and kids with PTSD can have irritability. And either one of them can have angry outbursts. So kids with ADHD tend to be easily frustrated. Like they have a hard time persisting at tasks. They tend to get frustrated easily. And so they will have angry outbursts just because they're frustrated and can't persist at tasks. Kids with PTSD may have angry outbursts that seem surprising because kids with PTSD are overreading hostility in the environment, or they're overreading the danger or the threat signals. So I'll tell you a brief aside because I think we've got time here. There was a study done years ago with early 2000s with a bunch of 9-year-olds. And so the researchers took a video of somebody going from like a little video of somebody like smiling, going to angry. And if you take a video of me doing that, like you are right now, you can stop frame it and get all these little faces of me, partly smiling, partly, with angry grimace on my face or something. And the researchers took all those little stop frames and rated them. This is 100% happy. This is 50% happy, 50% angry. This is 70% happy, 30% angry, whatever. And so they brought in 9-year-olds and they showed them just one of the pictures. In this picture, pick one emotion for this picture. Well, they would show them the pictures and ask them to pick one emotion for each picture. And so they would say, oh, this is happy, this is angry, this is happy, whatever. And the typically developing 9-year-olds started calling the faces angry when they were at about 70% anger, according to the researchers. And when they brought the kids in who had physical abuse, so they brought in a bunch of 9-year-olds who had physical abuse history, and they asked them with the same pictures to give one word for the emotion. I don't know if any of you guys have room in the chat to say, or had access to chat, what percent angry do you think the faces were when the kids started to say this is an angry face? Who has a guess? Nobody's had any guess. Was 40%. 40%. Yeah, okay. Yeah. So 40%, less than half. So definitely kids with ADHD, kids who have been physically abused and might have PTSD, but kids who've been physically abused, they're overreading signals from other people. So let's just say I'm a teacher and I'm asking the kid to get back in their seat, and I'm like, Johnny, and I make a little face, or I cross my arms, or I kind of tap my foot, or I do something, I give them my look or whatever. That child who's been physically abused and has PTSD, they may have that all of their danger signals have gone up. They think I'm angry at them and something bad is going to happen. They can't see that as just, like I'm giving them a stern look or something. They tend to think like, I'm going to be hit, I'm going to be thrown out of school, I'm going to lose my placement, I'm never going to see my dad or mom again. They kind of catastrophize all of this, or at the very least, they just think that they're in danger. So that may be a teacher, but what if I'm like their foster parent? And then they think I'm mad at them and I give them a stern look. They think I'm gonna hit them, or I'm their grandma or their aunt or whatever. Then so they have these outbursts that look to all the rest of us completely unwarranted. But for them, they felt like they were in they had all their anger kind of warning bells going off because their amygdala is overreactive. So they have these angry outbursts. So you kind of have to try to tease out, what do these angry outbursts look like? Are they like, I'm getting frustrated at trying to do, kids with ADHD will sometimes like throw their controllers on the ground with their games. They're playing a video game and they're having fun, but they're frustrated because they're not doing well. And they're throwing their game controllers down or stomping on them, or they're trying to do something with their schoolwork and they're like, and they get irritated trying to do their math and tear it up or something. And that's kind of more ADHD versus a kid who, the teacher just gives them the redirection and they get upset, and maybe just be the interpersonal aspects of overreading it. And kids with trauma often insert themselves into other people's issues. The teacher will say, he won't mind his own business. I'm talking to this kid about you need to get back on task. And then he comes over and starts talking, telling me not to talk to the kid in that tone of voice. And so kids with trauma insert themselves into other people's situations again, because they're watching for danger. So their danger signals are going off all over. So you can sometimes you have to get more details about, tell me about these reactions, these angry outbursts, tell me about this sleep, tell me about this distraction, to kind of figure out, is this ADHD or is this trauma? Ideally, if we're working with kids that ideally all of our clinics have some way to screen for adverse childhood events. Hopefully we're asking about adverse childhood events, DCF involvement, bullying, or the impact of racism on the family or the child, to kind of have an idea of who that we're treating has been exposed to trauma. Now, not everybody who has a trauma has PTSD. Only 30% of kids who have a trauma where they feel that their life or the life of somebody that they love is in danger, or that somebody's going to get significantly hurt. 30% of kids who have a trauma develop PTSD. So not all of them, but if you're working in some clinics, have virtually tons of the families, tons of the kids have had trauma in their lives. So we have to kind of think about, well, is this ADHD? Is this trauma? And so keys to teasing it apart are, number one, to establish, have there been traumatic events that have occurred? And is there a timeline related to ADHD symptoms? Was this kid doing perfectly fine in school, and then there was domestic violence that occurred in a relationship, they were removed from their family, and now we're seeing trouble? Well, obviously that would make it easier to figure out. Difficult because some of the kids are so young that they didn't have much school history, or the trauma's been so persistent that you can't really tease that apart. Like I said, you want to identify, is the kid on high alert looking for danger? Are they experiencing intrusive thoughts? Sometimes I ask kids, when you're sitting in class and you're not doing your work, what are you thinking about? Are you thinking about, what am I going to eat for lunch? And you're thinking about the video games you're going to play when you get home? Or are you thinking about your mom and wondering how she's doing? Are you worried? Are you thinking about things that happened in your life in the past? Or are you thinking about worries about something that's going to happen in the future? Kids with ADHD are usually just thinking about fun stuff. I'm going to go home, I'm going to play my game, I'm going to pet the dog, they're just thinking random stuff. Versus kids with trauma are thinking about their relationships and negative events in the past. So sometimes I ask kids, like, what are you thinking about when you're not doing your work? You might see that, or what are they drawing? If they're drawing, what are they doing? What are they drawing? Are there avoidance symptoms? So are there things that they avoid? Like, will they not want to watch movie in school if there's movies about family circumstances or about poverty or something like that? Obviously, do they have nightmares with traumatic themes or separation themes? And are they overreading people's intentions? So kind of all that. I might be asking about those things if I know a kid has had trauma and I'm trying to tease it apart. I want to know there's a family history of ADHD because that may help. And realize they're not mutually exclusive. Kids who have ADHD are more likely to have been abused physically, because they're kind of overwhelming to people. They may not be listening, they're not remembering your instructions, they're kind of all over the place. So any kid who has ADHD is more likely to have been hit or physically have undergone physical abuse than other kids. And kids who have ADHD, if they experience a trauma, so if they already have ADHD and now they experience a trauma, they are 4 times more likely to develop post-traumatic stress disorder once they've had a trauma, as compared to typically developing kids. So it can be, it may not be that it's an either or, but it's both. And then you have to decide what options do we have for treating them? What order do I want to treat in, or how do I want to layer my treatments? So treating a kid with comorbid PTSD, obviously if we can, we want to have the kid go to psychotherapy. Usually trauma-focused cognitive behavioral therapy, trauma-focused CBT, that's the gold standard treatment. Kid has to usually be at least 8 years old and kind of at a normal IQ level, somewhat, maybe not psychologically minded, but at least 8 years old, kind of a normal learning to be able to do cognitive behavioral therapy. So younger than that, we often do play therapy. So you kind of are playing with kids and watching for the themes that come out in their play. So you play with them with like house, like family, like things that are like houses and families, and kind of see what they represent, because kids communicate through play. We might do family therapy, trying to help the adults communicate safety to the kids, help repair attachment difficulties, build bonds within the family, make sure we've got good communication, and that kind of thing. We certainly encourage, we might encourage kids and families to do mindfulness practices or meditation. They've actually shown that meditation, a daily practice of meditation, about 10 minutes a day, can, over the course of a month, improve concentration. So it actually helps ADHD, improving concentration, and it reduces emotional reactivity. So a daily meditation practice can be very helpful for the kid, can be also helpful for the family. And part of that is because if you're doing meditation or doing breath work. So if you do breath work every day, you're increasing parasympathetic nervous system tone. So you're trying to rebalance. You're trying to decrease the sympathetic overflow that people are kind of stuck in fight or flight with PTSD, and bring up the parasympathetic nervous tone. People call that the rest and digest nervous system. So trying to rebalance those. So having people not just do breathing when they're upset, but every single day doing breath work, at least 5 breaths of some sort of breath work where you're holding the out breath for a long time. So you can teach kids to do box breathing, and you can tell them a little story about how they teach the Navy SEALs box breathing so that they're ready when something, scary is going to happen, or something that requires a lot of focus. You can do 4, 7, 8 breaths. People can use apps like Insight Timer or Headspace or Calm in order to do the breaths. And sometimes I just tell kids, simply like, we're going to sniff in the flowers, like sniff the flowers, breathe in and hold, and blow out the birthday candles, purse your lips, blow all the candles out. Get the last one. So you got to get all that breath out, right? So most kids can relate to that. So if they don't like any of the other things, just 5 breaths, sniffing the flowers, blowing out the birthday candles. I'll ask the family to pick when are they going to do that throughout the day. So at least 5 times. I got one family that does breaths at stoplights when they're in the car, at red lights. When they're at the red light, they do 8 breaths. It's kind of an interesting thing for them to do. Now, not all kids, if a kid is struggling with concentration, let's say a kid has ADHD and comorbid PTSD, they might not be able to benefit from psychotherapy if they're very inattentive or very hyperactive during the sessions. So sometimes we need to treat a kid's ADHD or to treat some of their hyperactivity or inattentiveness just to be able to get them to benefit from the psychotherapy part of PTSD treatment. And if we're going to treat ADHD with comorbid PTSD, we have to realize that giving a stimulant may make them feel more anxious. They may raise their heart rate a little, and kids with PTSD can be very sensitive to their heart rate going up if they begin to physically feel panicked, and that triggers them into like an emotional panic. Like, so some kids who have PTSD can't really go to amusement parks and ride roller coasters or do things where there's a lot of excitement, because it triggers like flashbacks for them. So sometimes we might not want to use a stimulant. We often consider a non-stimulant first. We often use alpha-2 agonists because they may, in addition to, they just help the hyperactivity, the impulse control, help them feel more calm. It can sometimes decrease hyperarousal. They've studied alpha-2 agonists. They've studied long-acting guanfacine for ADHD. It's not approved for that, but there's some studies showing, not for ADHD, for anxiety. So they've studied guanfacine extended release for anxiety, and it's got some effect there. So a lot of times, and an alpha-2 lasts all day long. So if we can get a kid like to calm a level and we can do it all day long, then that may then help them, learn other effortful control. They may be able to make gains in how they regulate themselves. If we can get them a little less panicked, a little less reading, you know, threats in everywhere. We don't have an atomoxetine, which is Strattera. Atomoxetine um, is a selective norepinephrine reuptake inhibitor, so that's similar to bupropion. So it might improve mood. And interestingly, when they've used atomoxetine with kids with autism, they get a little bit of an anti-anxiety effect with atomoxetine. Might see a little bit of that with a kid with PTSD as well. So I'm a little bit more, and atomoxetine increases norepinephrine, but not as robustly as a stimulant, right? So I'm a little less likely to trigger flashbacks, panic attacks, things like that. And if we think about, if you're thinking, well, if this kid has ADHD and PTSD, or maybe I can't tell, and I think that they're having some hyperarousal, wouldn't I want to treat their PTSD with medication? Well, there's no medications that have been really shown to help kids with PTSD. In adults, we use SSRIs. They are FDA approved in adults, but all of the studies, there's been 4 or 5 studies with sertraline or other SSRIs for kids with PTSD, and it does not create significant improvement. So they don't seem to respond well to medication. So that's why we're sending the kid to psychotherapy if we can. If a kid's on a wait list for psychotherapy, or can't get them into psychotherapy, I'm going to ask them to do at least some deep breathing every day, or encourage them to do 10-minute meditations together every day, maybe yoga, anything that or Tai Chi, anything that incorporates some breath work to help, and then going to treat their ADHD probably with a non-stimulant first. And then, if we need to, we add a stimulant. I mean, I definitely have kids that have comorbid ADHD and PTSD on a stimulant, but I usually didn't start there. I usually started with a non-stimulant, see how we do. Sometimes we are able to, answer questions with our pediatric hotline, so that I think some of you might be using our telehealth services. We also do have there's also the Florida Behavioral Health Collaborative Pediatric Hotline, where primary care doctors can call and usually within a 24-hour period talk to one of the child psychiatrists here at USF, where we can kind of give you little tips about maybe people tell us about a little case, kind of like a curbside consult, tell us kind of what's going on in general. We might say, well, for that kind of a case, we'd probably consider this medicine or that medicine. We give a lot of advice about how to titrate between medicines, or which ones to start with, or what are the treatments we might recommend that you try to find in your area, what kinds of treatments to recommend. One question in the chat was about, are there studies showing that if you treat children with ADHD, that improves the myelination? Well, I would never think that was the case, but yes, the Shaw, SHAW, in the early 2000s, he was the one who did some of this imaging research, and he did see that they took the kids with ADHD, did a baseline MRI, treated some with stimulants and some without stimulants, re-imaged them some interval later, I think like a year later, and the kids who had been treated with stimulants had closed the gap between themselves and healthy peers on myelination more than the kids who had not gotten treatment. So it actually looks like the stimulants might improve the myelination process. Don't exactly know what the mechanism is for that, but that did seem to happen. I don't know if those kids are just sitting down and eating better, if they're just, I'm not sure, but there was improvement there. So I have another question in the chat. Let's see. Okay, so let me talk about this one, and I'll go back to the military question. So could go over the pharmacology of alpha-2 agonists, guanfacine and clonidine. Well, they're in the brain, and so peripherally they lower blood pressure, but they work centrally to increase norepinephrine. So all of these treatments for ADHD are increasing norepinephrine and increasing dopamine. That's all that they do, or that is what they do. Stimulants increase norepinephrine and secondarily dopamine. Methylphenidate is mostly increasing norepinephrine, and it does it pretty robustly. Secondarily, dopamine gets increased. Amphetamines increase norepinephrine and cause a more direct release of dopamine. So amphetamines are often felt to be a little more powerful because they're more directly affecting dopamine, but I also feel like they're not as well tolerated in a lot of kids. So we usually start with methylphenidates if we're doing a stimulant. The non-stimulants all increase norepinephrine. So atomoxetine increases norepinephrine. The newer one, Qelbree, which I'm going to blank on the name right now. I think it's aloxazine. I think that's it, aloxazine. That increases norepinephrine selectively, and both of the alpha 2s increase norepinephrine in the brain centrally, but peripherally, they're affecting the alpha receptors, which can lower blood pressure. Kids generally tolerate the blood pressure lowering very well. So, I mean, this is just where, medicine was originally developed for something. We find out it has other effects. And I try to tell the parents that the long-acting alpha-2 agonists are FDA approved. They are studied for ADHD. They are FDA approved to treat ADHD by themselves, and they were actually studied with stimulants. So they are FDA approved to take in combination with the stimulant. So depending on the complexity, we have lots of kids that are on a stimulant plus an alpha-2. So they're on a stimulant plus a non-stimulant. And so, but it said most kids are. Have I had a few kids that had bradycardia? Yeah, I have. But most kids tolerate it just fine. So the guanfacine ER, the intuitive studies, they used 0.1 milligram per kilogram per day as a maximum. So we make sure we're staying under that for guanfacine. So you usually only titrate up by 1 milligram a week or down by 1 milligram a week. So you start, at 1 milligram per week, per day, and then you go up to 2 milligrams. It's been studied any time of the day. So they've looked at giving guanfacine ER just at night. Good ADHD control all day long. So you can use it in the morning, you can use it at night. So if the kid is like a little sleepy or a little fatigued, that can make you a little bit more irritable if you take it in the morning. So we may move that to nighttime. So, alpha 2s, we're watching for sedation. If you're looking for low blood pressure, it's usually, headache or dizziness, looking pale, looking unwell. So that's kind of, I don't know if that answers the questions as far as alpha 2. Another question was about military entry in ADHD. Well, that kind of depends on which branch of the military. So you have to kind of look at which branch the kid is looking at and what their rules are. Generally, so I think there's some branches that won't take you if you've had ADHD treated. I think there's some parts of the Air Force. But some of the others, like the Marines, the Army, most of the time, what it is people have to have been functioning without ADHD medication for a year, and then they can go into the military. So I've got some kids who will have a debate about should they stop their medication in high school so they can go right into the military. I might have to write a letter saying that they've been stable off of their medications. Now, the military almost never checks. The recruiters ask you, but recruiters are like, you've never had ADHD, have you? Nudge, nudge, wink, wink. You've never had it, have you? Great. We mark no on the form. We go forward. That can cause problems. It's rare that the military looks for a reason to stop somebody from joining. So, it's up to kids and families as to what they report. But if you report that you've had a history of ADHD, if you report honestly, I've had it, then you have to be off of medications and functioning well for a year. So what does functioning well mean? But we have to kind of figure that out, and then you can write them a letter, and then they typically can go. So we've got some kids that are in families that decide it's more important that we graduate from high school, go work doing something for a year while we let the clock, tick around until we can join the military. So question about how do these treatments transfer over to adults who have been diagnosed with ADHD and also have a history of PTSD? Because I'm not sure what you mean by transfer over. Virtually anything that works in kids works in adults for ADHD. I don't know. 17, do you want to unmute and ask me more like what you're thinking of or what part? Oh, I don't hear you actually. Maybe that won't work. No, I'm static. Okay, that didn't work. So, like I said, almost anything that works for ADHD in childhood will work in adulthood. Those are the question as to what's been studied and is FDA approved and will be covered by insurance. Those are always other questions. So if you use an alpha-2 agonist, if you're using alpha-2 agonists, They work, most of us feel like alpha 2s work better for the hyperactivity and the impulse control, not quite as well as for focus. So it kind of depends on, usually it's what symptom domain is still causing a problem. So typically as you get older, the symptom domain that's causing problems is the inattention. That's what's causing people to not pay attention to work instructions, to get fired because of poor attention to detail, not staying organized, not paying your bills, stuff like that. So once we get past puberty, the focus tends to be, sometimes it's on impulse control and doing just stupid stuff, but a lot of times it's more on, adults usually want more help with like focusing, being productive. So we may more often be using atomoxetine with them. Sometimes they're using stimulants as well. And, and if an adult has PTSD, again, you have to see, like for somebody who has PTSD, they may not tolerate their heart rate going up. So again, so once they're older, they have PTSD, if there's still residual anxiety, you can certainly, in adulthood, you might be able to use an SSRI to bring down some symptoms. You might be able to use, trazodone or something to help make sure somebody with PTSD is sleeping, or prazosin. Prazosin, works for nightmares for people with PTSD. So prazosin might be helping them sleep well, which then might help them be focusing better and be, if you're better rested, you're focusing better, you're doing better. So, to comment on medication shortages. Super painful. That's all I could say about the medicine shortages, is it was super painful. I don't know when we're going to get ourselves back out of this. I've read commentaries to say that prescribing for stimulants went up by 30% during COVID pandemic, over the 3-year period. A lot of adults felt pretty overwhelmed, multitasking, a lot to manage with kids that didn't have as many activities or in school, that kind of thing. So the prescribing is up. There's shortages for all kinds of things, shortages of Adderall, shortages of Concerta, shortages of Metadate, shortages of Focalin. So it's kind of like, now we spend half of our day, luckily the pharmacists are being helpful most of the time. They'll tell people, look, this is how much we have of this dose. Call your doctor and ask for 20 tablets of a 10 milligram, because that's what we have. So I'm having to be creative. Some people, rather than using, Adderall XR 20 twice a day, I'm using half of a 30 and half of a 10 twice a day, something like that. So, it's another reason to start people on non-stimulants if you think that they could tolerate that, or if it fits their symptom profile. Yeah. So, like I said, we're certainly not, we're not really seeing, any shortages of like the alpha 2s or atomoxetine with Strattera. So you could certainly use those medications. We do use bupropion sometimes. Bupropion, if somebody has depression and ADHD, it can help concentration. It's not as good as methylphenidate, but there are studies showing that bupropion, because it's a selective norepinephrine reuptake inhibitor, it can help focus for some people. So sometimes we use that if there's a reasonable indication for that. Not FDA approved in kids for anything, but we use it off label. And so in kids that do not have a federal insurance, so kids that don't have Medicaid and so kids who don't have Medicaid, if they've got commercial insurance, Astaris, which is a new long-acting dexmethylphenidate, they have a good coupon where it only costs people like $50 a month for a year. So some of the newer medications, like Cotempla, or some of them have coupons that can be helpful if they don't have Medicaid. If you've got Medicaid, you can't use a coupon. Any comment on the new video game? Prescribed it yesterday for the first time. Mostly when we see any of those kind of trainings, mostly what we see is that the effects don't tend to generalize. So I haven't used that particular game to see if it generalizes. But I know, like for adults with dementia, and they have people play games and stuff, what they see is that people get better at the game, but it doesn't generalize very well into the rest of their life. So they may indeed get higher scores on something. So I think there's a question as to whether or not we see generalization. So I don't know if anybody else has prescribed Endeavor and seen any positive responses with it. Don't know. All right. Appreciate all of the questions. If you guys have more questions, or if anybody wants to unmute or ask anything else. There's certainly information on both the pediatric health hotline and the consults at the Florida Center for Behavioral Health Improvement and Solutions. So there's a number of the services that are available at that link. All right, I hope everybody has a great rest of your Friday and a good weekend.